Let's start at the bedside. You've got a patient. Their life is absolutely hanging in the balance. Multiple organ systems are failing, and every single decision you make in the next few moments could change, well, everything. Now, who's the one physician that's been trained from day one in physiology, pharmacology, and resuscitation, ready to manage all of those systems at the same time? Well, that's us. Today, we're going right to the heart of where our skills are tested the most, the ICU. We're going to explore our foundational role in literally creating critical care and how we continue to define its future.
You know, it doesn't matter what language we speak or where in the world we practice, we are all united by this shared dedication to our most critically ill patients. It is fantastic to have you here with me as we dive into the leading edge of that practice. All right, so let's get into it. Here's our roadmap for today. First, we're going to unpack our own incredible history as the true architects of the ICU. Then, we'll get into the real nuts and bolts of running a modern, high-quality unit. After that, we are going to take a really deep dive into the evidence that completely transformed how we manage ARDS and sepsis. Then, we'll explore the tool that's revolutionizing our bedside practice, and you know I'm talking about POCUS. And finally, we'll look to the horizon at the really exciting future of acute care.
You know, to really get a handle on our importance today, we have to go back in time. And it's an amazing story. It's one that I think fills every single one of us with a real sense of pride. See, the modern intensive care unit wasn't just influenced by us, it was literally invented by one of us.
So while other people were creating specialized care units, the big paradigm shift, the real big bang of critical care, happened in 1952. Just picture this scene. Copenhagen is being gripped by this terrifying polio epidemic. Patients are dying from respiratory paralysis. The standard of care, the negative pressure iron lung, is just failing catastrophically. And into this crisis steps an anesthesiologist, Bjorn Ibbesen. He had this radical insight, born from his experience in the operating room. Why not just bypass the failing respiratory muscles and ventilate the lungs directly with positive pressure through a tracheotomy? So, he gathered these patients into one room, staffed by medical students who manually ventilated them 24/7. It was an act of incredible, almost unbelievable ingenuity and endurance. He didn't just save countless lives, he created the very first ICU.
This quote just captures the essence of our contribution perfectly. It's in our DNA. Our deep, intuitive understanding of physiology and our comfort with life-sustaining technology have always put us right at the vanguard. I mean, from pioneering CPAP in neonates to developing the very first blood gas analyzers, we have consistently been the innovators, always pushing the boundaries of what's possible for the critically ill.
Okay, so let's fast forward from that first improvised unit in Copenhagen to the complex, high-tech environments we command today. Because how we structure and staff these units, well, it isn't just some administrative detail. It is, quite literally, a matter of life and death.
A massive body of research has looked into the impact of who is running the show in the ICU. And the conclusion? It's undeniable. A high-intensity staffing model, where a board-certified intensivist is physically present and directs all patient care, leads to significantly better outcomes. And we're talking about real outcomes. Lower mortality rates, shorter ICU stays, shorter hospital stays. This is the model that's endorsed by all the major quality organizations, and it places our expertise right where it belongs, at the very center of the critical care team.
This table really breaks down the formula for success. The data suggests there's a sweet spot for that intensivist-to-patient ratio, right around 1 to 7.5. You overload the intensivist and care suffers. The impact of nursing is also crystal clear. Having a nurse look after fewer than 1.5 patients is directly linked to a lower risk of death. But the real magic ingredient, the force multiplier, is the multidisciplinary team. When we lead daily rounds that bring together the expertise of critical care pharmacists, our amazing respiratory therapists, and our PT and OT colleagues, that's when we see the absolute best outcomes for our patients.
Okay, let's switch gears and talk about one of the most feared and complex conditions we manage, acute respiratory distress syndrome. For years, we thought we were helping these patients with our ventilators, but a landmark discovery revealed that we were often, completely unintentionally, causing harm. This is a story of a complete and total paradigm shift.
So first, let's be really precise about what we're talking about. ARDS isn't a disease in itself. It's this devastating syndrome, a final common pathway of lung injury from triggers like sepsis, trauma, or severe pneumonia. The lungs become completely waterlogged with inflammatory fluid, not from heart failure, but from leaky capillaries. They become heavy, stiff, and just profoundly unable to get oxygen into the blood.
Now, to make sure we're all speaking the same language, and to guide our therapy,
We use the Berlin definition. It's a simple but really powerful tool that classifies the severity of ARDS based on just one metric, the degree of hypoxemia, which we measure by the PaO2/FiO2 ratio. And this isn't just academic. As you can see in the table, hitting that severe category with a PF ratio under 150 is a critical threshold that triggers very specific life-saving interventions.
This concept, this absolutely revolutionized our thinking. CT scans of patients with ARDS revealed something startling. The lung isn't uniformly sick. Large parts of it are collapsed and consolidated. So the entire breath we deliver from the ventilator is being forced into this small remaining relatively healthy part of the lung. In a 70-kilogram adult, this functional lung might only be the size of a child's lung, and that's where we get the name baby lung. Realizing this was the key to understanding ventilator-induced lung injury.
And here is the direct consequence of that baby lung insight. The old way, using these big 12 milliliters per kilogram tidal volumes, was like trying to inflate a birthday balloon inside a coffee mug. We were overstretching and injuring that small, functional lung with every single breath. The new strategy, lung protective ventilation, is completely different. It uses tiny tidal volumes, just 6 milliliters per kilogram of predicted body weight, and crucially keeps the plateau pressure below 30 to prevent that dangerous overdistension.
This represents one of the most important clinical trials ever done in critical care, the ARMA trial. It tested lung protective ventilation against the old traditional approach. The result was a stunning 9% absolute reduction in mortality. Just let that sink in for a second. This wasn't some marginal gain. This was a home run. It fundamentally changed our practice overnight and became the absolute, non-negotiable standard of care for every single patient with ARDS.
So, okay, low tidal volumes are the cornerstone, but what else is in our toolkit? Well, PEEP is essential. It provides that constant pressure to splint open the alveoli and stop them from collapsing at the end of each breath, a damaging cycle we call atelectrauma. For severe ARDS, prone positioning is an absolute must. Turning patients onto their stomach for over 12 hours a day uses gravity to recruit collapsed lung areas and has a proven mortality benefit. Now, to achieve lung protection, we often have to accept a higher CO2 level, permissive hypercapnia, as long as the pH stays in a safe range. And finally, paralysis. This is where it gets a little tricky. An earlier trial showed a benefit, but a more recent, larger one did not. So the current thinking is to use it sparingly, with boluses rather than continuous infusions, to help with ventilator synchrony without causing prolonged paralysis.
All right, now let's tackle the other giant of the ICU, sepsis. If ARDS is a fire in the lungs, sepsis is a fire raging through the entire body. It's a fast-moving, incredibly high-stakes condition where our ability to apply the latest evidence directly translates into lives saved.
The modern Sepsis 3 definitions brought some much-needed clarity. Sepsis isn't just about inflammation anymore. It's about the life-threatening organ damage that happens when the body's response to an infection just goes completely haywire. And septic shock is the most extreme form of this, where the circulatory system is in total collapse, leading to a much higher risk of death.
So how do we quantify that organ dysfunction? We use this tool, the SOFA score. If you look at the table, you can see it gives us this real-time objective assessment of 6 key organ systems. In any patient with a suspected infection, a jump in their SOFA score of 2 or more points is our clinical trigger to diagnose sepsis. It's our bedside scorecard for identifying sepsis and for tracking a patient's trajectory, for better or worse.
Our playbook for this is the Surviving Sepsis Campaign Guidelines, and the 2021 update really honed our approach. Crystalloids are still king for that initial fluid resuscitation, but a huge point of emphasis now is the shift away from static measures like CVP. The guidelines now strongly suggest we use dynamic measures to predict fluid responsiveness. The MAP target holds steady at around 65. Norepinephrine is absolutely cemented as the first-line vasopressor. And, importantly, tying back to our ARDS talk, the guidelines now recommend against routine stepwise recruitment maneuvers because of a lack of benefit and potential for harm.
When a patient is in shock, we have to think like a physiologist. There's a logical sequence of questions we have to ask. First, are the vital organs getting blood? We look for clues like lactate, urine output, mental status. Second, what is the pump doing? We need some kind of estimate of the cardiac output. And third, and this really is the million-dollar question, if I give more fluid, will it actually help, or is it just going to end up in the lungs? Answering this question has always been a challenge, but what if we could actually see the answer in real time?
That question provides the perfect bridge to what is, I would argue, the most transformative tool to enter our field in decades.
Point-of-Care Ultrasound, or POCUS, has become our new stethoscope. It's our window into the body, allowing us to answer these complex physiological questions instantly, right there at the bedside.
For us as anesthesia intensivists, POCUS is just a natural extension of our hands-on approach. It's not about replacing formal imaging. It's about answering specific yes or no questions quickly to guide our immediate management. Is there a pneumothorax? Is the heart squeezing well? Is the stomach full? POCUS gives us those answers in seconds.
Let's start in our home territory, the airway. POCUS is a complete game changer here. We can use it pre-procedure to predict a difficult intubation. After the tube is in, a quick look at the neck can confirm tracheal placement with nearly 100% accuracy. You can literally see the tube in the trachea. And for procedures from central lines to perc trags, it's really no longer optional. Ultrasound guidance is now the standard of care for safety and for success.
Now, let's look at the lungs. This image here is what you should see in a healthy, air-filled lung. You put the probe between the ribs, that bright white line at the top, that's the pleura. In a healthy patient, you'll see it shimmering and sliding with each breath. Below it, you see these horizontal, repeating lines. We call these A-lines. Seeing lung sliding and A-lines tells you two things. The lung is up and it's dry. This is our normal base.
Now look at the dramatic difference in a wet lung, like an ARDS or pulmonary edema. The A-lines are gone. Instead, we see these bright vertical beams shooting down from the pleural line like laser beams. These are B-lines. They represent fluid in the lung's interstitial space. Seeing more than 3 of these in a single view, especially when they start to merge together, is the sonographic sign of interstitial syndrome. It's a powerful and immediate way to diagnose pulmonary edema right at the bedside.
This image really demonstrates the power of POCUS to track disease progression. As the lung gets more consolidated in worsening ARDS, we start to see this. This is the shred sign. It's that jagged, irregular border between the aerated lung above and the dense, sort of liver-like consolidated lung below. Finding this tells you the disease process is advancing, and you can track its resolution or progression day by day without ever leaving the bedside. Okay, let's move to another incredibly practical application, especially for us. We are constantly faced with patients who have an unknown fasting status. Gastric POCUS gives us a non-invasive way to look inside the stomach and make a real-time assessment of aspiration risk. This table is basically our cheat sheet. With the patient lying on their right side, we look at the antrum. If it's empty, it looks like a collapsed bullseye. That's low risk. If it's full of clear liquid, it'll look black or anechoic, and we can actually measure the volume to stratify the risk. Anything over 1.5 milliliters per kilo is considered high risk, and if we see solid food, it has this classic frosted glass appearance. This is always a high-risk stomach. This simple exam can fundamentally change our anesthetic plan from a standard induction to a rapid sequence intubation. So as we bring all of these threads together, our history of innovation, our mastery of physiology, our adoption of powerful new tools, what does the future actually hold for our specialty? Well, the answer is incredibly exciting. We are moving way beyond the traditional silos of the operating room and the ICU.
The future is integrated. The whole concept of acute care anesthesiology sees us managing the sickest patients throughout their entire hospital journey. From the initial resuscitation in the emergency department through a complex surgery, managing them in the ICU, and even following them onto the ward to make sure they have a safe recovery. Our unique 360-degree skill set in physiology, pharmacology, and procedural skill makes us the ideal physicians to lead this new comprehensive model of care.
I want to leave you with this one final thought. Our specialty has a legacy of leading from the front, from inventing the ICU to establishing life-saving ventilation strategies. Now, armed with tools like POCUS and a constant stream of new evidence, the question for our generation is, how will we continue that legacy? How will we harness these advances, not just to be excellent clinicians, but to be the innovators who once again redefine the very definition of critical care? I'm excited to see what we build together. Thank you so much for joining me for this explainer.